So good afternoon again, everyone. My name is Casey. Thank you for joining today's session. And on behalf of the PRRP Exchange team, we are excited to have you all here today. This is our first state partnership update session of the PRRP Exchange. This is a forum to hear from others implementing recognition programs. This helps us to achieve our goals, which were set forth by the group for the exchange. So today you will have the opportunity to hear updates from your peers on their state and territory emergency department and pre-hospital recognition programs. So we are excited to learn from those with well-established programs and from those who are just getting started. Before we get started with that, in today's session, we would like to acknowledge that the EMSC Innovation and Improvement Center is funded through a cooperative agreement with the Health Resources and Services Administration, which is within the U.S. Department of Health and Human Services. As a cooperative agreement with a federal agency, the EIIC must adhere to executive orders and related federal guidance currently. EIC-funded staff are unable to engage in activities or discussions on topics that are limited by executive orders. We appreciate your understanding and ask all meeting attendees to refrain from discussing any topics of concern defined within executive orders. Additionally, the contents of today's presentation are those of the authors and do not necessarily represent the official views nor an endorsement by HRSA, HHS, or the U.S. government. A few housekeeping items before we hand things over to you all. Today's session is being recorded and will be posted to the EMSC website along with today's presentation on the newly launched PRRP Exchange page. If you missed any of the PRRP sessions last year, these recordings can also be found on the Pediatric Readiness Recognition Programs page. As always, we look forward to having an interactive session with you all, and we ask that you turn your cameras on. You can ask questions of one another by raising your hand and coming off of mute. So again, we look forward to your contributions during today's meeting. We have invited a number of states and territories to share an update during today's session. For those who were able to join today's call, we will go in alphabetical order. You may share a verbal update on your ED or pre-hospital recognition program, or you may share your screen and display any slides that you have prepared. For those who are just getting started on their programs, we will hear about the enablers that have been helpful, as well as barriers that they have run into. This is a good opportunity to get feedback from your peers who have perhaps run into the same barriers and have found ways to overcome those. And for those who are just getting started, we can learn from what enablers they have found to be helpful. For those with more developed programs, we will hear a bit about their application and verification process, as well as what marketing strategies they are implementing. So there are lots of opportunities to hear how others are implementing and enhancing existing recognition programs. We look forward to an engaging discussion. So again, this is a time to ask questions of one another and to receive support and feedback on your recognition program, taking advantage of the many diverse perspectives on today's call. So with that, we will go ahead and start handing things over to our presenters. Don't think we have anyone on from state, so I think we'll go ahead and get started with Idaho if you're ready. Stacey, I can either share the slides or if you would like to take over and share.
No, if you could share it, I'll just say next slide, that'll be perfect.
All right, I'll hand it off to you.
Okay, well, good afternoon, everybody. So next slide. This is a new program for us, so bear with me as I present this to you. So for the Idaho Pediatric Readiness Hospital Recognition Program, the EMSC Advisory Committee aimed to create a program that's attainable for all of our hospitals. Idaho is 88% rural, so we have a lot of critical access hospitals. So we wanted to make sure there were no barriers for those majority of the critical access hospitals that we have to become pediatric ready. So we wanted to have it this program be attainable, promote evidence-based guidelines, and integrate with the NPRP. But most importantly, we wanted it to be an effective program and not just be like a rubber stamp. We wanted to ensure that we were creating pediatric readiness throughout the state. Next slide. So we started accepting applications January 1st of 2024. We made this free and voluntary for all hospitals, and we did determine to have three levels. We have expert, advanced, and capable, and the recognition is valid for 3 years. Next slide. So for our application process, I've highlighted some stuff. I did create a manual. I'm more than happy to share all of this. Just for the sake of time, I didn't include any of this, but did create a manual that included the something that the hospitals can check out before applying. And then they can determine the most appropriate level, but it does have the step-by-step process in this manual. It includes the criteria, how I would, take this to the MSC Advisory Committee. So just so that the way there was a lot of questions answered prior. And then we also decided to ask the facility to retake the PRRP and submit that with the application along with required charts and documentation for the criteria. Next slide. The EMSC Advisory Committee physician, I have an ED physician that reviews the charts to determine compliance. The committee developed a rubric that he utilizes depending on which level the hospital is applying for. And then he sends that rubric over to me. And then once I get that, I schedule the on-site review. And I am the one that attends the on-site review for just to be cost effective. I'm not paying I do pay the advisory committee physician to review the charts, but then I go out there and I do the on-site review. So I check out all the equipment. And if there's any documentation that hasn't been submitted with the application, I go through those policies and ask questions and talk to the team. We only require that the ED manager and PEC are on the on-site review, but everyone they can invite. We've had like teams of 15 and we've had teams of 3, and then I do talk to nursing and other staff while I'm on the on-site review. I did highlight here a no surprise survey checklist. So the checklist that I go over is the exact checklist that's on the application. So again, I am more than happy to send the application so you see, but they do see all of the things that are required, policies, there needs to be a PEC, and then all of the equipment is on a list. So I have that exact same checklist. So that way they're not wondering, what am I writing down? Everybody knows what we're looking for. I also there has been a lot of critical access hospitals that couldn't afford certain things. Trachs are expensive and so forth. So Idaho EMSC has helped purchase certain items to ensure that they were pediatric ready before the actual survey. We also can combine this. Idaho EMSC is housed within the time-sensitive emergency program, so we can combine these surveys with trauma, stroke, or STEMI surveys, which has been really helpful. And then once I do the on-site review, the physician, Dr. Simsprat, and I present this to EMSC Advisory Committee. We have our meetings January, April, July, and October. And then I created my own little report that I type up and present to the committee, and so does Dr. Simsprat, so that way it's consistent. The committee did agree that because some hospitals apply in between these meetings, we don't want them to have to wait. So we do schedule little meetings in between to recognize a hospital, so that way there's no time, like a long period of time that they have to wait. Next slide. Facilities notified by email within a week. And then I do take a picture when I am on the on-site review, and I hoard that picture until they're recognized, and then I send that to them with the email. So that way they can use this. We did purchase a banner that looks just like this banner kind of thing on the side over here. And then I send that picture to them so that way they can use that picture for their market, like advertising of being recognized. And then we do mail them a certificate. Again, they're valid for 3 years. And then I attend all state regional meetings, and I haven't done my newsletter lately because we're in a little bit of a move, but include all of that and try to blast them as much as I can. Next slide. What I did before we rolled out this program, I just wanted to say, because I do attend state and regional meetings, and even during the development of this, I made sure to let everybody know that this program was coming. Gave some presentations on, updates, updates, encouragement. And then I directly emailed all of the facilities that manual that includes a letter with access to the applications prior to the rollout. So that way they had time to take a look at that. Next slide. And then what I'm doing now is I do review all of the trauma applications that come in for designations. And then I reach out to those facilities and encourage them to apply and do whatever I can to assist. I have been following up with hospitals who have inquired. And then I give updates about the recognition program at all of the regional and state meetings. And then I like to point out that it's not a program that's coming out to pass or fail you. It is definitely a program that encourages pediatric readiness, and basically you apply to become pediatric ready. And it's been very exciting to see hospitals really progress. And then I attend state conferences and I give a lot of information out about the recognition program. Next slide. And we have 6 hospitals recognized. Very excited. I've got a 7th one coming up. These are the pictures that I take and send out to the hospitals, and the ones that I use as well. Next slide. And this is my committee. Well, not all of them, but this is who was at the last meeting. Great group of people.
Thank you so much, Stacy, for sharing. You already have a question in the chat from Cynthia. Do you have a closed portion of your EMSC advisory that is not part of the Open Meeting Act for the hospital discussion?
I'm sorry, what was that again?
Do you have a closed portion of your EMSC advisory?
Yes, I do. Because I have regional PEC leaders. And so there are certain members that don't vote. I have mainly my core members that ensure that, that we vote on that.
Thank you for your answer. What other questions do you all have for Stacy? Or Stacy, if you have any questions for the group, you're building your program.
Any advice? I mean, it's a learning process. I feel like, as we continue to go through this, we're learning. St. Luke's Children's in Boise here did hire 2 full-time PECs in their house. They are a full-time FTE. And so they just started. I've been super excited, but one of the new things that we're going to start doing is every time we recognize a hospital, David and Jennifer will get that information. They're creating a network. So like I said, just as we continue to do this, we're learning. Pretty excited though. I am really excited to see how, like I said, to see these hospitals progress and see how effective this has been so far, but always open to ideas. And I'm excited to see what y'all are doing.
See that Cindy's having some audio issues. We'll see about maybe you being able to call in later on, and maybe we can hear from you then. Looks like next up we have someone on from Mississippi. Andrew,
Good evening.
welcome. Would you like me to share the slides that you shared with me, or you can?
Yeah, that's fine. That works. That works.
All
Um, so here in Mississippi, we actually have a trauma assistant program, kind of similar to how Idaho has. And we decided to look at their system, and they kind of already had a pre-placed pediatric system specifically for trauma. But they're kind of delving into burns and pediatrics and they're working on a sepsis committee as well. And so when we understood they were doing that, we decided, well, instead of trying to reinvent the wheel, we just decided to kind of combine with them. So if you want to move to the next slide, that'd be great. So at first, when we made the committee, reestablished the committee, we kind of talk about two different systems. We did a checkbox systems to kind of consider like, hey, if they are pediatric ready or if they're not pediatric ready, and we kind of decided against that one. Then we tried to talk about a tiered system where we talked about primary, secondary, and what we would call a community, where it was one that it didn't have all the resources that we needed. It was kind of limited. It didn't have the equipment. It had limited equipment. The best thing it could probably do is what we would consider a Band-Aid station style hospital. And we talked about that, and when we were talking about that with the trauma system, they kind of already had an idea in mind, because since they already had a tiered system, they kind of like, well, here's our tiered system. Do you want to imitate it? To make it kind of cohesive for well, not only for us and them, but for the hospital as well. So that way there's no confusion between terminologies. So move on to the next slide. So what we decided to do is, when I talked to my committee about this, and we decided to officially adapt their moniker. So what they go by is they go by tertiary, tertiary, secondary, and primary. So their tertiary system is what we consider a level 1 hospital. That has your children's specifically their own standalone children's ER. It's not combined with the adult ER. It's its own standalone ER, its own ICU, its own surgical console, and any other resources it pretty much needs that to function as a standalone children's hospital. Your secondary, which has dedicated facilities and services for pediatrics, but does not necessarily does not cater only to pediatrics, or specifically have their own section in the hospital. And then we have our primary, which is our what they would consider Band-Aid stations. What we consider Band-Aid stations, kind of like our lower end, like not our hospitals that are kind of rural, very out in the middle of nowhere. It doesn't really have the resources to take care of the children it needs to take care of, but still wants to participate, still wants to say that, hey, we're not going to say we're not going to take care of children, because you can't, but just we don't have the resources to completely do what we want to do for them. So some of the bonuses for doing that, combining with the trauma care system in our state, was they have their own separate set of funding, and they have their own set of team. I know their team comprises of, I think, 5 to 6 people. They have somebody that's from their staff or their committee. They have a tertiary / secondary medical director, a tertiary or secondary, these are level 1, level 2 the hospitals, trauma nurse, and then I think the other 2 are kind of filled up with either specialists in the field or ER docs to kind of fill just kind of the roundabout kind of areas that those guys are not specialized in. So it kind of made it easier for all of us to do that. And the only thing that I foresee, because it's relatively new, my committee relatively, or it's not relatively new, my committee recently adopted the moniker here, and the only issue that I foresee is when it comes to making a decision, there's going to be a little bit of bureaucracy, having to slow down the process, because we have to agree as committee, then we have to go to them, and they have to agree as committee, and then we have our superseding committee, which is our EMS acute care systems committee, which supersedes both of us. And then we have to go to the essentially board of health to kind of have them convince it. So it's kind of a process and maybe a little bit of pain to get through all that, but there is a process to kind of get through all that. It's kind of like if things are already in works, it's going to get done. If it's not in the works already, it's going to take a long time to do. If that kind of makes sense. If you don't mind, next slide, please. So the other issue that we realized with the barrier part, some barriers, is that there's not yet a sepsis. It's in the works, but it's not created yet, and been in kind of a development situation for about, I think, a year or so now. So that's kind of an issue that we're having. Another one is the way that their disaster planning is made is kind of a little complicated. Instead of having like instead of the document for the trauma care system, or our document saying that they need to have this, this, and this, it's written in there where they have to have it by EOQ standards for the state. And so that kind of adds another layer of planning, which we're kind of getting around that right now, because we actually have talked to our local agency that does the emergency planning, and we are actually adding on a pediatric annex to kind of update the emergency operation plans to have a pediatric specific section. You move on to the next one, please. Or that might be so some of the things that we have are working on is we have as the advisory committee for Mississippi have agreed and have submitted a update for the Mississippi trauma acute care systems equipment list, the MTech list. It has a lot of the stuff that the EMSC suggestion list has, and the only things they don't have on there is, besides medication, is the continuous it's like a long word, a continuous I think it's continuous air pressure, positive air pressure, and nasal cannula for pediatrics, and then just the 5 and 8 millimeter or 5 or 8 French feeding tubes, and we requested that they add on that to the at least the tertiary, and see if we can add that into secondary as well. The how their list is set up is they have like separated into tertiary, secondary, primary, and if they're required to have it, if they're not required to have it, but it's suggested, or if they're not if they are not required, not suggested. And then, like the other section of this slide says, collaborating with our strategic planning division to make so we created a task force to create this plan. We added members on theirs, members of our committee, members of our staff, and as well as a member of the local tertiary hospital that specializes in pediatrics, and came up with a annex that can be added on to our emergency operation plans for disaster planning, to kind of help with the lack of pediatric specific goals. We move on to the next one, please. One more, or maybe two more. I think the other one just talks about, yeah, that one just talks about the tertiary, secondary, primary, and then I think there's one more slide, and I think that's it. Yep. So that link is to our trauma registry, where you can see that how the description of the tertiary, the secondary, and primary are. And then that second link, it takes us actually to all the hospitals that are accounted for. I think we have 90 hospitals in the state, and I think 87 of them are signed up to the trauma care system designation, trauma care system designation. That so when you look at that list, you'll see like that's all the hospitals that we account for, and it will say something along the lines of this is a primary, and then it has a comma, and then it'll tell you if it's a primary or secondary or tertiary hospital, which is the pediatric side, and it'll have pediatric next to it. Next slide, please. Yep, that kind of describes the different designations of the hospital. So whether you can designate, I think it says you can designate yourself or we designate for you, and then the hospitals that choose not to be a part of the program, if they choose not to be part of the program, they have to kind of pay a kind of like a fee. So we kind of, the trauma care system kind of set up a pay to not play situation. Next please. So some of the things that we did for as far as like marketing, that we try to kind of put ourselves out in public. So the community awareness, I've talked about maybe in the past, I've maybe talked about the safety fair and our 55th anniversary. We promote not only ourselves as EMSC, but we promoted local businesses that focus on safety, organizations that focus on safety, as well as inviting our sister committee for MTAC to come along and participate with us. These are free events because they're held by our MSDH. And so when we do one, we promote anybody that wants to come participate. This last year we had a couple of schools come by and actually take pictures, and then the local news took pictures, and we had a little demonstration of each one. I think our trauma care system people came out, and our ambulances and EMS services came out. We had a local firearm training academy come out, and they kind of showed safety and gun safety, because that's kind of a prevalent thing. Shows them how to hold a gun, what not to do with it, what to do to it, because these are things that are not common, that if people don't know, they're not gonna know exactly what they're supposed to do with the kind of situations, as well as our fire marshal's office to kind of do some fire safety stuff. And then as far as involving playing with other organizations, we go to different conferences. So our trauma care system actually sets up a trauma symposium that provides education, as well as some cool things like a cadaver lab, where you can kind of understand the body more. So I don't think it's a public invitation, but it's a invitation for professionals that allows us to kind of talk to different individuals in specialist fields and get our name out there. We also participate in Partners in Preparedness. That's less of medical professionals and more of our disaster professionals. Those are people that work with like power lines and emergency services, police officers, firefighters. Ones that when they don't deal with medical stuff, they're dealing with hurricanes and situations where roads go down, the lighting services, the generators. And then Mississippi's for EMS, which is our local EMS, pro EMS specific education / convention, where we talk to other EMS individuals, provide education for them, and talk about different topics in relation to EMS and how we can be involved with other stuff. So some of the stuff that we involve professionally, to kind of show that we support our EMS, we support our firefighters, support our local schools, and support our hospitals, to kind of get our name out there. And I don't know if that helps or not, but that's pretty much it. That is my presentation. I know I kind of speak fast, and I don't know if y'all heard me enough.
Thank you so much, Andrew. Lots of great examples of ways you're integrating with other organizations and sort of working together to accomplish that same goal. So I appreciate you sharing the work that you're doing related to that. It seems like you're getting started in this work, do you have any questions for the group today? Or maybe anyone else who's working with their state's trauma program can share your experiences. We can help each other out here.
I do have one question for the group. I don't know how to the approach. So obviously I have a way in for the hospital side, but I'm having issues with trying to do a recognition program for the EMS side because most of our stuff is company based, or private company owned, and then some of our stuff is state. Mostly northern stuff is state. But uh, trying to figure a way to do a recognition program where we don't try to make them, I guess, make it, try to get them to all agree, as well as not fighting over territories, maybe, or fighting over, hey, we're better in this, we're doing this kind of situation. Or trying to find a way to kind of get them all to agree on a standard that they would all be willing to. If that makes sense. I mean, that might be a complicated or loaded question, but that's the issue that I'm currently dealing with trying to get the EMS side on the recognition note.
Hey, Andrew, just on the ED side and working with trauma system, this is Kate Remick, and we have been doing a tremendous amount of work with that in Texas, as I'm sure you've heard from Sam and Sally and others, Catherine Kathari and the like. But it took a long time to get there. The trauma rules in Texas had not been rewritten or revised in 20 years. And the initial push for pediatric readiness integration was not necessarily met with a huge amount of opposition, but I think all in all, when the first most recent draft was published, there were some like 600 plus public comments about the depth of it. And ultimately, there were some minor revisions made to pediatric readiness within the trauma system. And the reason that so much of it got pushed through was exactly the kind of work that you're doing of bringing in all these other partner organizations, which I think has been critical in making it happen. And the other thing that I would just add is that while Texas was successful in getting the trauma rules rewritten to incorporate pediatric readiness requirements related to a number of domains of the guidelines, so equipment and supplies and education for nurses and competencies and QI and a few other aspects, there is still the EMSC Pediatric Readiness Recognition Program, which stands apart from what has been integrated into trauma. And so one thought is that if you don't get everything you want within the trauma system or approach for EDs, is that you could still perhaps separately offer a PEDS recognition program outside of that adds to get you up to the next level. Just a thought.
Thank you.
And then the other part of your question was related to getting started with an EMS recognition program and how to bring everyone on board. Is that sort of the root of your question, Andrew?
Yeah, that's the hard part, because it's we have, specifically this year, we have a bunch of companies kind of like taking over other territories, some companies shutting down, and then some other companies involving other companies. So it's constantly moving around here, specifically this year. But yeah, that's kind of the situation I'm finding myself in.
Who else has maybe had experience with that or is currently having a similar experience?
Hey, this is Tasha in Tennessee. For our EMS recognition program, we, in our state advisory committee, we have like an EMS team, And so there's some nurses, but mostly EMS personnel that make up that committee. And we are housed at a university, so we met with the EMS office to make sure they were on board with what we were trying to do. And then we just had that committee kind of create a draft of it. And what we did is we have our state is split up into different director associations. So we took that draft that we created and went around and got all of their opinions on it and let them review it and ask their questions and add to it. And then we took that to our PEC committee as well, and let them, as like the end users, kind of review it and let us know their thoughts and what needs to be changed or anything like that. And then we just recently took it to our EMS board for official approval. And so now we're working on implementation. But that's kind of how we got like we kind of came up with our draft with some of our key experts that we work with all the time. And then we took that around the state to all the different leadership and some of the end users to get their thoughts on it.
Thank you for sharing.
Thank you.
Anyone else having a similar experience? Hearing no others, thank you again for sharing. Next up, looks like we have Virginia. If you would like, you can share your own slides or I can navigate them for you.
Can you hear me okay?
I can hear you.
Okay. Yeah, mine will be relatively short. We did not have on our work plan to begin working on this till years 3 and 4 of the grant. So we're basically here to gain value from the experience of others. And you did express that was one of the points for the collaborative. We're working to build a core team. We're in the process of reimagining our EMS system in Virginia. So we've had kind of a speed bump in the road that actually is presenting some opportunities for the future. And it's one of those things that needs to happen periodically to move forward. But we've had to eliminate lots of positions. We've had to restructure our regional councils and their responsibilities and a number of other things. So our usual liaison type collaborations are somewhat different at this point, but it seems to be moving forward in a positive manner. So keeping that in mind, we will be creating a program development action plan, and we'll steal from everybody we can to try to not recreate things that are really a good idea. And I am trying to keep track of the resources on both ED and the EMS side. And this is actually all going to be going to someone else shortly. Next slide, please. One of the problems in the past, and actually 15 years ago or so, we almost established a voluntary system for the hospitals. But there was some confusion with our already established trauma designation program, and that was sometimes a problem. We had a lot of opposition from the State Hospital Association, and that essentially they were worried that this would result in additional regulation, hospital regulation, which to them means expense as well. And they weren't convinced there was a cost versus benefit ratio that was important enough to them at the time. There were other political considerations. There was a state legislative audit a number of years ago, 2008, I think, that essentially said that the pediatric hospital system in Virginia was just fine the way it was and didn't need to have anything done. So that was a hurdle for us at the beginning of the UMSC program. Next slide, please.
Bye, y'all.
Love you.
Program barriers on the EMS agency side. We have probably 65–70% of agencies in Virginia that are volunteer. And that's a pretty large percentage. Also, these areas, some of them are small, some of them are rural. And those folks are stretched thin. The staffing challenges we've had as an industry have translated here in Virginia as well. And we have less and less numbers of people being able to volunteer. And they're already required to have several different designations by the state, infection control officers, et cetera, blah, blah, blah. So there is a pushback in terms of trying to designate PECs. We are looking, though, at having a regional approach to that in some areas where they can combine their resources, and someone will take on the task of helping coordinate several agencies. And I think that might be a logical thing for some of the trauma programs to get involved with helping facilitate too. So that's just my opinion there. So it's always a difficulty to get that kind of a position implemented when they're already kind of overwhelmed with their scope. We're looking for a verification process that won't be overly complex, but still be effective. And then once we've got the program started, we've got to worry about being able to keep track of the data and keep it in a meaningful format and easily updatable. Next slide, please. Enablers. Well, I'm assuming that meant things that are going to help us. And so I think the biggest thing right now is we have been participating in the collaborative, and that has really given some great ideas. We haven't been ready to move on some of those yet, but we will be shortly. And I think some of the problems we have had in the last 18 months have made it difficult for us, but we're also going to have some things available to us we didn't have before in terms of regional collaboration that I think may in the long run benefit us in terms of the EMSC program. I think some of the attention that was garnered nationally last year on the pediatric readiness of hospitals has helped probably with hospitals' posture toward looking at this. And one of the best things is that I will be leaving shortly, and we're going to have new blood in the EMSC program. Mike Berg is on this call, and he has a lot of experience and a lot more energy than I do. And he's not unknown to a lot of the people on this call. So he will be taking over for me, at least in the short term, if not the long term. And anyway, next slide, please. Then they'll be moving on to phase 2 and actually go farther with naming the stakeholders and looking at the criteria that we came up with. At least the basic criteria. We'll probably add some of that in Virginia, but we'll use that baseline that you developed. And then all these best practices, hopefully out of that, we can come up with something that's not terribly complicated. And because we have limited resources right now to spend on this kind of program. And so we want to get the best bang for our buck. We'll get a timeline. We'll work toward the future verification process and see what we can do. But I think I'll just leave you with that. I know that we don't have anything developed at this point that's of any consequence, so I won't take up your time with that. I just want to thank the people on the call for all the great ideas they've given us and the resources they've shared with us. And I'm done.
Thank you so much for sharing today, David. And we appreciate your career and your time spent on pediatric readiness. So thank you. All right. Well, as the program in Virginia is sort of just getting started and considering some of the resources that have been shared, I don't know if the team from Virginia has any other questions for the group as you're moving into the second phase, or for others who are maybe just leaving phase 2, any lessons learned to share with them as they begin this next step.
This is Mike Berg. Dave, thank you for the compliment. That's yet to be confirmed whether I'm going to be that instrumental. I know I've got big shoes to fill. But I think our biggest challenge right now is the reimagination of our EMS system, the way that it's been done for the last 40, 50 years. This reimagination, I think, is going to be a great step. However, we need to see how this works out. And then I think we can take advantage of some of those things that are going to change. One such example is we currently have 11 regional councils. We will be going to 7, and there will be a greater involvement of the Office of EMS, where the EMSC program is housed, to work collaboratively with those regional councils closer. And so therefore, those challenges that David mentioned earlier, particularly with some of the EMS agencies, I think our relationship will be even stronger with these agencies and come up with some more imaginative and productive ways of being able to get this information not only to the hospitals and to the agencies, but also to be able to be more compliant with the need to get the equipment and the training and information out, and then being able to recognize the successes of these programs. So it's not a wait and see. It's a little bit of a wait and plan. So I'm hoping by this time next year, we'll have a much stronger hold on where we're going and exactly what we're doing. But I will be reaching out. I know some of you personally, so I'm not afraid to reach out.
Thank you so much for sharing. Looks like our 4th speaker was unable to reconnect for audio issues. Is there anyone else on today's call who has an update, something exciting that's recently happened that you would like to share with the group, or a recent struggle that you might need some advice from the group on? Hearing nothing, let's go ahead and share with you update on our schedule. So we will be seeing those who are interested in joining in June for the next pre-hospital focus group discussion. You should have all received that calendar invite on your calendars for that meeting, and we look forward to hearing from you then. And then looking ahead, we hope to hear more updates from you all again in August and November. So those who have been invited to share an update would have received a calendar invite separately with some additional information about that update. So we look forward to seeing you during those ED and pre-hospital focus group sessions in June and July. And then we aim to see you in August for our next state partnership update session. So we ended a little early today, so we can give you your time back unless you would like to use it to chat with one another. We appreciate you joining today's session. I hope you have a great rest of your day.